Good afternoon, everyone. My name is Kathleen Pereira. I will be facilitating today's webinar. Thank you for joining us. This webinar is about integrating behavioral health, and it's related to the Learning Collaborative that we conducted this year. Before we begin, I want to review some housekeeping items. We will have a high number of participants on this call, so participant lines will be muted. If you have any comments or questions, please submit them at any time using the Q&A feature. That is at the bottom of your Zoom link or your Zoom window, and you will see that icon. Closed captioning is also available. You can view the captions on your screen size. You might see the ellipses at the bottom of the screen right below more, and you can click on it there and click on the closed caption and then also size that up. If you experience any technical issues during the webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at samsa.sta@jbsinternational.com. And lastly, this is a recorded event, and your participation grants consent to the recording or to be recorded. And the recorded webinar and the PowerPoint slides will be available at a later date. So Sierra, we'll go ahead and move to the next slide. I just want to make a note that the material in today's presentation, they do not necessarily reflect the views, opinions, or policies of SAMHSA. And our next slide is about joining the conversation. So as people continue to join today, please take a minute to say hello by telling us your name, any other information that you would like to share in the chat. We would love to see that, see a little bit of interaction there. For today's agenda, I'm going to briefly go through our plan here. So in a moment, we're going to hear a welcome from SAMHSA. I will then provide a bit of information about the Learning Collaborative experience. We'll hear from 8 states that participated in the Learning Collaborative. They will share their experiences and the lessons that they have learned. While they are presenting, be sure to take notes if you have any questions or comments, because what we'll do is we'll save a little bit of time at the end of this webinar. You can talk about your experiences, you can ask some questions, maybe discuss some issues that you're really grappling with within your agency. And then we'll end this with a few closing remarks and ask you for your feedback in an anonymous survey for this webinar. So I want to now just introduce you all to Tara Andrews. I'm super, super pleased to have her here. She has been such a support to us throughout this process. Tara is the special assistant to the director in the Center for Mental Health Services at SAMHSA. She joined SAMHSA after about 7 years working for ARS treatment centers, which are headquartered in Kennett Square, Pennsylvania. And she served in several roles there, concluded her time as the CEO. She also served as a project director for the state of Delaware Family Court and worked as a director of performance improvement, licensure, and accreditation for a Delaware-based nonprofit that provided SU and mental health treatment services. She also managed a SAMHSA Mental Health Transformation Grant and a co-occurring state incentive grant, so a COSIP grant for the state of Delaware. So she was the perfect person to be our contact for SAMHSA, and we thank you so much, Tara. We thank you so much, Tara, and if you would please do your welcome statement.
Thank you, Kathleen. Good afternoon, everyone, and welcome. This Learning Collaborative has been a major commitment for all those involved, and I want to thank everyone who's contributed and those who have joined us today to share what they've learned with their colleagues across the nation. First, I want to thank each of the states that participated, all those involved from those states, and special thanks to the state representatives from Connecticut, Illinois, Indiana, Iowa, Michigan, New York, South Carolina, and Texas. Each brought their own challenges, strengths, and experiences to enrich each session. And we're very thankful for their commitment to this Learning Collaborative and the commitment of all their colleagues to the hard work of implementing the changes discussed in these sessions. Thank you to the speakers that joined our sessions. They provided valuable perspectives and expert knowledge and best practices on various topics, which you're going to hear more about, along with feedback to the states on their case challenges. I also wanted to just thank Kathleen, Matthew, and their colleagues for their hard work organizing and facilitating each of these sessions. And today we're coming together to review the benefit of the work, accomplishments, and lessons learned over the last 6 months of this Learning Collaborative. We hope all those that participated in the Learning Collaborative found it valuable and that their experiences and lessons learned will be valuable to the many other states joining us today. Lastly, a reminder that while this Learning Collaborative is now complete, the work to improve systems of care and services across the nation continues, and SAMHSA and its technical assistant contract is available to support these ongoing efforts. So I look forward to hearing from everyone today, and thank you, Kathleen. I'll turn it back over to you.
Well, thanks so much, Tara. So now I'll provide just a brief overview of the Learning Collaborative and some of our lessons learned over these last several months. On the next slide, you will see the 4 objectives for the Learning Collaborative. So the first one is really to share and learn best practices and promising approaches for state mental health authorities to integrate behavioral health systems. The second one is to identify barriers that prevent those authorities from comprehensive integrated behavioral health solutions and identify strategies for remediation. To apply lessons learned and share best practices and promising approaches through a case challenge activity, which we'll talk about in just a few minutes. And then finally, to document the practices, processes, and lessons learned by both participants and subject matter experts to expand peer learning and for dissemination for all mental health block grant grantees or funded entities. Now, let's talk a little bit about what we mean when we say integrating behavioral health, because that in and of itself sometimes can be a little confusing. So the journey that led us to our Learning Collaborative and this webinar began with SAMHSA identifying the need to support state mental health block grantees as they integrate behavioral health within their state systems. So as we think about the definition for integrating behavioral health, which again, that can cause confusion and people can think about it a little bit differently sometimes. Our focus was on a learning collaborative that would integrate mental health and substance use disorder services, because states are at very different places in that integration. Some are a little further along, some are not so far along. And so, how can they better serve individuals with co-occurring disorders and create a truly cohesive service system for mental health and substance use disorder treatment to work together? So that was really the focus of this learning collaborative. And Tara mentioned our states, but here they are on a map. And just to let you all know how this works, SAMHSA sent invitations to all states and territories to assess their interest in participating in the learning collaborative. And then in early spring, they selected the 8 states to participate. You'll see that they're all here. And then each state had one participant on the mental health treatment side of things, and then one on the substance use disorder side, because we wanted to make sure that there was equal representation and that they were truly working together. It gives that really strong perspective from both sides. There were a total of 16 participants, so there are 2 folks from each state. And let's talk a little bit about the SWOT analyses, which was an important component of the Learning Collaborative. So as the states were preparing for our in-person session, which happened in March, they prepared a SWOT analysis prior to that first session. The states were asked to conduct a SWOT analysis and present it to the full group. And they were also asked to identify a case challenge that was relevant to integrating behavioral health supports and services for their agency or their area. And those priority areas or those priority challenges really rose to the top as they completed their SWOT analysis. So we'll talk about that case challenge again in just a minute. But let's first talk about the SWOT analysis. So as we think about that SWOT, we wanted folks to focus on the internal strengths that they could use to remediate their challenge, such as leveraging existing internal resources, processes, and partnerships. Challenge, such as funding opportunities or aligning efforts with other external factors, and then external threats that could impede their progress toward remediating their challenge, such as fiscal or political trends and other uncertainties. So, for example, if a state is struggling to integrate substance use and mental health services, and one of the biggest impediments is just frankly confusion by the providers on what integration actually looks like in their day-to-day practice, They, you could look at some internal strengths, and maybe there are already established collaborative referral networks across mental health and substance use, so that you already have those set up, and those are going to be like kind of your lower hanging fruit. You might have internal weaknesses that are related to staff shortages. We know staff shortages are such a huge issue right now, right? And then also making sure that folks are properly trained and that they're comfortable with treating individuals with co-occurring disorders. An external opportunity might be an opportunity for training of all staff, even in other agencies, across both substance use treatment and mental health. And then an external threat might be varying payment rates for mental health versus substance use disorders, which is also something that we're hearing a lot about. So the case challenge itself, again, building upon that SWOT analysis, they were asked to work on this case challenge, again, relevant to integrating behavioral health. And they focused on this case challenge throughout the Learning Collaborative. Each of the teams used the Learning Collaborative, which included activities, presentations, discussions, and work with subject matter experts and additional resources to address their case challenge. And we will, each of the states will present on their case challenge here in just a few minutes. But to show you a little bit about what it was like, what we asked folks to do is to start with a case challenge overview. So getting a background of their case challenge, their historical context, that would help us clearly understand the challenge that they were facing. They discussed relevant data, evaluation data that they may have, evaluation data that they want to collect that they don't have. Different things like that. And then key partners. So thinking active partners, inactive partners, potential partners. What does it look like when they define success? How will they know that they're successful? And then really grounding that in SMART goals. So making sure that their goals were specific, measurable, achievable, relevant, time bound. And remember, we only had 7 months. So one of our challenges was to think big, but not too big, so that they could actually see some progress within that 6 to 7 month time span when we met. So there were some key challenges in integrating behavioral health that bubbled to the surface really quickly. So during our first Learning Collaborative meeting in March, some of the things that rose to the surface and really continued, our discussions continued on these throughout our Learning Collaborative, were related to regulations and policy. So changes in regulations and policy are needed to support the integration of behavioral health, and for it to be truly systemic and sustainable change, they really have to be concretized and clarified in regulations and policies, and that's something that we've heard across the board. We also heard a lot about the need for both top-down and bottom-up approach to integrating behavioral health. So having those champions that are at the highest levels in the agencies, at the state level, but also just knowing that you have to have the support of providers and folks that are actually going to be actually implementing this for it to be successful. Reimbursement rates and funding streams continue to be a real challenge. That came up many times. And the regulation change without changes in funding or reimbursement will not enhance integration. So that was something that we've heard a lot about. Differences in reimbursement rates for mental health versus substance use disorder treatment continues to create significant barriers also in integration. Speaking of integration, data integration, that was something that came up a lot. Like, how do we make sure that our partners are communicating with each other and that they're serving clients in a really cohesive way? And to have a good data system is the way to make that happen. Providers also show a lot of mixed support for integrating behavioral health. There's stigma, there's resistance to change, just their overall discomfort in serving individuals that have co-occurring disorders and feeling like they don't have the training that they need. And speaking of training, we've got training opportunities and workforce shortages, which continue to be pretty significant. So really thinking about cross-training as being so crucial, and then also how we address the workforce shortages in this field. So after our first in-person session, we had 5 virtual sessions, and we had some phenomenal speakers. So session 2 on common regulatory barriers and related strategies in integrating behavioral health. Our subject matter expert was Joe Parks. And Dr. Parks is the medical director for the National Council for Mental Wellbeing, has a ton of experience as a psychiatrist in community-based health centers. He was a PI for 3 consecutive co-occurring state incent over this COSIG grant, so really understood all the way from the very top. We think about this kind of as a funnel, right? So from the very top and all those state level regulations and funding issues all the way down to implementation. For session 3, we had Mary Lou Sutters, who was in the Massachusetts Governor's Administration for 8 years. She was the Secretary of Health and Human Services, and she oversaw a lot of agencies, including the Mass Health Program. So she really understood, again, like how those fiscal pieces relate to the regulatory pieces, and then how to talk to organizations and various agencies during that implementation process. Dr. Saganya Sakalingam is a founder and former co-owner of Change Matrix, which focuses on health equity and justice. And she's now principal at TeamWorks International. But she was able to talk a lot about leadership, administration, and organizational culture, providing a lot of strategies on how to get folks to kind of play in the sandbox together. And then we also had a session on workforce development strategies. This was led by Dr. Brian Hepburn, who's the executive director of NASHPD, the National Association of State Mental Health Program Directors. And then we rounded that out with like truly boots on the ground. How do you implement this as a clinician? And that presentation was from Rick Krasinski, who's the director of the Center for Evidence-Based Practices. He is at Case Western Reserve University. Ton of experience in both substance use and mental health disorder treatments, and really thinking through how co-occurring disorders can best be treated. So just had a phenomenal group of folks that that spent their time with us. On the next slide, I've got 3 slides that I'm going to cover about strategic actions. So these were, I do want to say that these slides, I'm going to go through these pretty quickly. They are elaborated upon in our Learning Collaborative Resource document, which I'll mention a little bit later at the end of the session. But I do want to spend just a couple of minutes talking about strategic action as it relates to regulations and finance. And the first thing I want to say is that it became really clear that these are inextricably linked. So when we think about these, we really can't talk about regulations without the financial implications and vice versa, right? So one of the strategies that was identified by one of our SMEs was to develop a core rule that combines common language from mental health and substance use regulations, because often when you look at these regulations side by side, there are more similarities than there are differences. So really acknowledging those similarities, identifying where the differences are and how critical those differences are, so that you can get to a place where your regulations are truly aligned. The next one was creating a set of service definitions and taxonomy across relevant public health agencies. So when you're thinking about financing in particular, it's essential that there's an agreed upon definition for behavioral health. And so making sure that you're clear on where those state structures are, what the statutory authorities are, and getting those folks involved in some of those, in identifying some of those definitions and really concretizing those definitions. Again, related to definitions, codifying a definition for primary diagnosis. We know that this often impacts how services are billed. So having a clear definition of primary diagnosis and what that means for billing is super important. Also determine the percentage of funds that may be spent providing treatment for a co-occurring disorder. And the reason that I bring this up is because working with budget committees on determining these things is going to be really critical. So having agreement that a percentage of a provider's funds can be spent on providing treatment for co-occurring disorders, regardless of what their primary diagnosis is considered on that particular day. And we know that these tend to be very separate funding streams. And so that is something that has to be worked out. And also consider additional funding sources. So there's grant funding that helps to support some of these services. We know the grant funding isn't sustainable. So what are some other options? Where can you tap these, et cetera? Working with policy and payment reform in tandem. I've mentioned this a couple of times already, that that really has to be done together. And then aligning rates across programs. And again, this gets into like Medicaid, substance use, and mental health agencies, and developing a taxonomy for aligned rates. Okay, so when it comes to collaboration, do a quick time check here. Okay, I'm good. Okay. promote a unified vision and mission. So you really need to all have that clear vision of where you're going and why for you to have true buy-in and also to be able to communicate with each other. Agree on a core set of metrics. This came up a few times. So everyone, all these different agencies all want their own metrics and they feel like they're giving something up if they let one of their metrics go, right? So I do working together to identify core measures that can, and continue to refine those. But also think about not overburdening providers by just having them do more assessments or more metrics that they're measuring and reporting on. And then, of course, making sure that you're using those and reporting on them. Assess who should be at the table and be inclusive, like who are truly your stakeholders and how are they sharing in decision making. Foster open communication and transparency. So having regular interdisciplinary meetings, creating open channels of communication such as joint newsletters, internal platforms, etc., to facilitate ongoing dialogue. Offer cross-disciplinary training programs to ensure that all staff are equipped with the required knowledge and skills. Convene institutes of higher education to agree on co-occurring curricula. If you can hit those higher ed folks, then when these staff members are coming out of school, they are ready to go and they understand what the charge is. And then increasing the utilization of certified community behavioral health clinics, which will ensure access to coordinated comprehensive behavioral health care. And then next slide is going to talk about strategic actions as they relate to organizational culture and service provision. Now, I do want to just again say, I know that I'm going through these quickly. There was so much great material that came out of this learning collaborative. Each of these are elaborated upon in the resource document that we will make available. So I know I'm just hitting some highlights here. Okay, so remember I talked earlier about stigma and resistance to change. So as we think about organizational culture and service provision, we want to make sure that we're developing integrated treatment models. So forming those interdisciplinary teams, creating shared responsibilities and integrated protocols and pathways that really standardize how both groups or both fields collaborate for patient care is super important. Start with incremental change. So some people that are going to automatically be resistant to big changes. How can you identify particular service delivery pain points so that you can work on those, have success, and then continue to expand out? That's certainly a way to go. Continually work to build an agency culture that's open to change. So organizations that are open to change have a much easier time with this kind of implementation. Also kind of assess the appetite for change so that there will be success. Are they ready for this kind of change? Because it is a big endeavor, right? It's a big undertaking. Cultivate a culture of continuous improvement where staff are encouraged to learn from success and failure. And then the next one is working to get provider buy-in. So listening to providers' concerns about this kind of change, including their training needs and treatment capacity, because it is very natural for providers to be skeptical of big changes like this and have a lot of questions. So also, you'll see that I mentioned peers in here again, increasing the, I said stakeholders earlier, but peers, increasing the use of peers because they should be used in policy development in addition to being part of the treatment team. How do you get them at the table and making decisions? And then there were a few things that came up related to hiring and training. So one of our subject matter experts really highlighted this idea of hiring for character and then training for skill, because you can train folks for a skill, but you have to have the right folks in the organization and they have to be like truly a good fit for you and a good fit for the organization and understand the direction that you're trying to go within your organization. Offer cross-disciplinary training programs. I've mentioned that on a few slides now, so I think you get the gist. Allocate resources for professional development. If you truly want to see these kinds of changes, and if this is a priority, making sure that funding and other resources are available for people to grow professionally. And prioritize supervision. We actually had one subject matter expert that even said supervision might actually even be more important than training, because if you want something like this to continue to move forward and for you to really see the progress within that change, that it can't just be a one-off training. It has to be continuous supervision with everyone having the same goal. And then increase the utilization of technology. So We certainly know the impact that the COVID had when we were looking at telehealth and really expanding telemedicine. What are some other ways that technology can be utilized to expand your services? I think that it is time to turn it over to our states. So we're going to hear from the states regarding their state challenges. I think that you are all going to be very impressed with everyone's commitment to this work, their engagement in the Learning Collaborative, and where they have landed with their case challenges. We are going to start with Connecticut, which is Joanne and Katie. So you two are up.
Good afternoon. I'm Joanne Comstock. I'm a clinical psychologist and advanced addictions counselor with the Connecticut Department of Mental Health and Addiction Services. I oversee several programs in one of Connecticut's state-operated outpatient facilities, where we serve individuals with chronic and severe psychiatric illnesses and/or substance use disorders. My colleague is Katie McMullen. Katie works in the Evidence-Based Practices and Grants Division of the Department's Office of the Commissioner. Next slide, please. Thank you. Connecticut combined mental health and addiction services into one state agency decades ago, the Department of Mental Health and Addiction Services, or DMAS. Full integration of services might not have been supported at the outset because what we've seen that's transpired over time is a pattern of separation of services, either within agencies or across broader service systems. Administrative oversight and funding streams have perpetuated a culture of specialization, either in mental health or addiction services in both public and publicly funded agencies. There are gaps that exist between our administrative policies that promote provision of integrated care and the operationalization of those services at the direct care level. So it appears as though messaging around integrated care has not been consistently reinforced over time and across facilities at all levels of care that we offer. What we have at this time is a system-wide culture of treating each condition separately, either by specialists within an agency or referral out to other providers or services. And while we do have some agencies that perform better in this regard, as well as implementation of evidence-based programming like assertive community treatment teams, current best practices indicate that all of our facilities should be co-occurring capable. The Connecticut Case Challenge has been focused on identifying ways to disseminate the values of integrated care so our providers can most effectively adopt and sustain holistic co-occurring service provision. We identified this as the first step toward a longer-term goal of creating an effective co-occurring competent workforce where individuals can receive substance use and/or mental health treatment at any of our facilities.
So when Connecticut made the commitment to develop an integrated service system, we created, as Dr. Comstock just described, the Connecticut Department of Mental Health and Addiction Services. With those structural changes in place, we believed that the primary components of the integration process were successful. But fairly quickly, we began to notice that despite the integrated structures, silos remained. It took some time, but we realized that it's clearly not enough to just have an integrated system in name and policy if the structural changes didn't create meaningful integration of services for the individuals that we serve. We had the structures in place, but the values and skills to support full integration seemed to be lacking. So our priority objective became focused on ways in which we could strengthen and broaden integrated values and skill sets across our system. In terms of progress, our first step was to figure out exactly what was missing. So we decided to start with a co-occurring knowledge questionnaire. This questionnaire was broadly distributed and evaluated both knowledge and values of direct service staff and supervisors across our statewide service system. And the results were very interesting. Not only did the survey give us a lot of information about the wide range of values that our service providers held around co-occurring care, but the survey also helped us to identify a lot of knowledge gaps that existed around our staff's understanding of integrated service provision. With this information in hand, we've been able to target our efforts at system change. We've identified evidence-based practices and interventions for integrated services and are developing trainings for our staff statewide. These trainings are targeted specifically at the values and knowledge gaps that were identified in the survey and will not only be provided to our direct service staff, but also to their supervisors so that we can increase the sustainability of integrated values and skills over time. In terms of our lessons learned from this process, this is not the first time that the state of Connecticut has tried to integrate our services. It's not even the first time that we've rolled out intensive evidence-based trainings in integrated services. But this is the first time that we've done it in such a targeted way, informed by the actual gaps that exist. We've learned the importance of evaluating the actual needs of our organization before we try to make changes. When we identify these areas of needs, we're able to target our change efforts much more effectively. And with that, I will hand you all off to Ryan and Raphael from Illinois.
Hi there, good afternoon. I'm Ryan Rollinson, the Chief of Staff for Illinois' Division of Mental Health within the Department of Human Services. We're the state's mental health authority. DMH has a mission to ensure equitable access to a full continuum of preventive, supportive, and recovery-focused treatment resources that promote mental wellness for all people in Illinois. We're excited to be embarking on this journey of integration with our sister division.
And good afternoon. I'm Rafael Rivera, the Chief of Staff for the Division of Substance Use Prevention and Recovery. We are a part of the Illinois Department of Human Services. We're also the single state authority for substance use. SUPER, which is our acronym, provides for a range of prevention, intervention, treatment, and recovery services for both substance use disorders, and problem gambling. SUPER is approaching integration as an imperative to address whole person needs and in order to get away from treating a diagnosis. And with that, I'd like to pass it back to Brian.
Yep. Our case challenge focus was driven by the Illinois Governor's Office impetus for integration and a previous attempt more than a decade ago that was halted by the legislature. We want to make sure that previous missteps towards integration aren't repeated and that we're following the best path forward. In addition to the overall driving force, the two single state authorities have increased programmatic collaboration over the last 3 years, including some operational areas associated with specific funding sources. Integration was the next logical step as common areas, particularly around peer recovery support services, have brought us to the point where policy and operations need to be more integrated. Over the years, both authorities have heard from service providers about their frustration with barriers encountered when trying to navigate both systems to provide the best services possible to patients and consumers. We want to be able to address these concerns through the integration path we decide on. And finally, Illinois has realized that regardless of the level of collaboration, the integration of services is the best approach for our patients and consumers to support meaningful, impactful social determinants of health responses and reduce barriers to meet the challenges of behavioral health treatment as those we serve present with increasingly complicated issues. We want to move forward with integration and want to learn from others' experiences so that we end up choosing the best possible path forward. To that end, we're seeking outside resources and support, including external consultants to help guide our team's integration, and the excellent support and guidance through the SAMHSA Learning Collaborative. Raphael?
So our priority objective really is to identify and establish internal resources within each division to support further integration. At this point, as far as our progress, we've decided on moving forward with operational integration while also gathering as much stakeholder feedback as possible. A plan has been established, leaders have been identified to carry the work forward, and we're executing a contract with the external resources that will support the work, again, moving forward. The framework and overall plan has been approved by the governor's office and by senior leadership at the department. The most important lesson for us has been that everything will take longer than anticipated, while also learning how to manage expectations. Since once given the green light, expectations become immediate, critical, and urgent. Managing expectations will be critical moving forward, as is the actual work of integration itself. We're also focused on maintaining transparency, openness, and communication throughout the integration process, making sure that our employees, providers, and other stakeholders are entirely in the loop as we move forward. With that, I'd like to pass it over to our friends from Indiana.
Good afternoon. My name is Stephen Holland. I am the Assistant Director of Adult Mental Health and Wellness at Indiana's Division of Mental Health and Addiction. I am also a licensed mental health clinician and a credentialed sexually abusive youth clinician here in Indiana.
Hello, my name is Mark Loggins. I'm the Assistant Director of Addiction Services here at the Indiana Division of Mental Health and Addiction. Next slide, please. So while Indiana, as stated before, Stephen and I are both work at the Division of Mental Health and Addiction. We have an integrated mental health and substance use agency here at the state level. We have found that our providers are the ones who really struggle to integrate the two services. Our goal for this project was to focus on developing a model at one of our opioid treatment programs to integrate mental health services in-house instead of the current system, which requires community mental health center referral for treatment. So some contextual factors include the fact we chose our OTPs because DMHA, our division, has more oversight over addiction providers, with OTPs being the most regulated provider type. Additionally, the OTPs have demonstrated great enthusiasm at the prospective project and the ability to integrate mental health into their services, into their OTP services. While the OTPs focus on substance use treatment, GIPR data from the SOAR 3 grant indicates that over half of the clients are also report being at least slightly bothered by mental health problem in the last 30 days. So it's showing that there is some kind of a need there among those clients. A key aspect of this challenge has been identifying a payment method for the OTPs to offer mental health services. Obviously, grants are not seen as sustainable, so we need something more substantial going forward. The OTPs are currently covered by Medicaid under a bundled rate, which includes counseling services. The OTPs, however, report that these counseling services are really focused around addiction and substance use issues and are very ambiguous when it comes to mental health. Next slide, please.
Okay, so as Mark stated in the previous slide, Indiana's primary objective has been ways to identify how OTP clients can get mental health services in-house and have those services covered by insurance. This has led to several conversations and a significant partnership between Indiana's Division of Mental Health and Addiction and our Office of Medicaid Policy and Planning. The primary goal of those meetings has been to identify areas of clarification, identify gaps, and everything like that in the OTP's billing package. Our overall goal is to not cut into the OTP's bundled service payment. So the conversations are focused around either the OTPs registering as a mental health provider type in Indiana, or actually from very recent conversations that they would be able to just bill specific mental health billing codes. And then Indiana has a team that does audits yearly on the OTPs, which would then be folded into that team's audit process. Once we've fully figured out exactly how Indiana is going to do this, either by a provider type or by billing codes, we're going to be partnering with 2 or 3 non-CMHC affiliated OTPs and have them pilot the program and help develop a playbook. That way we can pass those off to our other OTPs and any other providers that are struggling with how to integrate mental health and addiction services in the same system. And with that, I will pass it over to Iowa.
Great, thanks so much, Stephen. My name is Justin Edwards, and I am the Substance Use Block Grant Planner for the Iowa Department of Health and Human Services. And I'm also here with my colleague, Kevin. I'll let him introduce himself. He may be muted. No. Good afternoon, everyone. My name is Kevin Gabbert, and I'm the State Opioid Treatment Authority for Iowa, and I also assist with clinical oversight of our substance use block grant and state appropriation funded treatment services. Perfect. Thanks, Kevin. Well, Iowa's case challenge is focused on certain elements of the planning and execution of a complete public funded behavioral health system redesign. From our vantage at the state, we can see a stark contrast in resources and services between our metro and rural areas. Our data and anecdotes from professionals and peers across the state show us that these problems contribute to varying degrees of behavioral health inequity. We see that we have siloed funding and, by extension, siloed programs. What Iowa HHS also had until recently were multiple siloed tables of organization in our own state agency. So our programs were not aligned, and the minds behind our legacy service delivery systems seldom had opportunities to align efforts. We're happy to report that Iowa HHS in its current state was formed out of legacy public health and human services state agencies. So that's one silo down. Then in the spring of this year, our governor, Kim Reynolds, signed new legislation into law that struck all existing Iowa code supporting the legacy behavioral health system and replaced it with the framework for a brand new one. This new system will braid funding, such as our mental health and substance use block grants, to expand service capacity, to facilitate a more agile response to emerging trends, and to support a true no wrong door approach to service access. This learning collaborative came at an opportune time for Kevin and me to influence the development of this new system through knowledge and feedback from our counterparts in the other participating states. Next slide, please. So this is no small task, and we've been through a lot of objectives and milestones over the past several months. Where we find ourselves in the process today, though, is designing administrative oversight of behavioral health services at a level closer to the people who need them. To accomplish this, Iowa will be selecting administrative service organizations as instrumentalities of the state who will administer the redesigned system. There will be 7 ASOs in total, each representing a district, which collectively cover all 99 Iowa counties. A new district map was released about a month ago in early August, and we're happy to report that the ASO request for proposal was posted to the public just this past week. Once selected, each ASO will create a district-specific action plan to assure behavioral health services are available in ways that match the unique needs of the individuals they serve in each district. Each district will have a unique makeup, and so each ASO will have the latitude to manage its own district-wide system. ASOs will also have the flexibility to collaborate across their district boundaries when needed, assuring that service deserts are mitigated as much as possible and that no one is denied services based on where they live. There have been a lot of lessons learned along the way, but one thing I really want to highlight is there is no place exactly like Iowa or Connecticut or Illinois or Texas or anywhere else. We took inspiration from other states and delivery system concepts already in use, but in the end, we realized that investing time and resources into understanding Iowa better would help us design a system that works best for us. The cornerstone of this process was our decision to contract with the wonderful folks at Health Management Associates, or HMA, to conduct a comprehensive assessment of Iowa's many existing service delivery systems. HMA offered great options for Iowa to consider, and their suggestions really affirmed for us that the problems with our existing systems couldn't be fixed with small strokes. Behavioral health in Iowa needs a fresh start, and so here we are. We still have a lot of work to do, but we're confident in the direction we're headed, and we look forward to welcoming our new ASOs to the fold on July 1st of 2025. So thank you so much for listening, and with that, I will hand the mic over to Lena and Michelle from Michigan.
Hello, I'm Lena Houston. I work for the public behavioral health system for about 13 years now, providing mental health services and co-occurring services. I currently work for the Michigan Department of Health and Human Services in the behavioral health, behavioral and physical health and aging administration, also known as BPHASA. Sorry, that's a mouthful. Providing oversight to our assertive community treatment teams, including 69 ACT teams / IDDT teams representing our dual teams across the state, and 12 standalone for our family psychoed and early act pilot program. Here with me today, I have my colleague Michelle Boudreau, who also works with BP HASA here with me. She has about 25 years of experience providing mental health services and co-occurring services. She currently has oversight of supporting many evidence-based practices across the state of Michigan for adults struggling with severe mental illness and co-occurring disorders, such as integrated dual diagnosis treatment, motivational interviewing, dialectical behavioral, trauma-informed care, and trauma-specific treatment, just to name a few. And so I'll hand the presentation over to Michelle to review our case study.
Okay, thank you, Lena. Before going into the case challenge, we wanted to acknowledge that we are fortunate to already have a foundation for providing integrated treatment within our system, and that we're trying to decrease barriers to full integration of mental health, substance use, and physical health services. Our case challenge focused on increasing knowledge and application of integrated treatment across the behavioral health system for dual act IDDT teams and IDDT only teams. Our task is to support the public behavioral health community mental health provider system to provide evidence-based practices according to Fidelity. We have 10 regions in Michigan with 46 community mental health service mental health organizations, not counting their contract agencies. Based on site visits, obtaining lower fidelity scores on the evidence-based practices, staff shortages, staff turnovers, new workers in the field, and struggles with funding and authorizations that are still siloed in some areas, we recognize the ongoing struggles with the application of providing fully integrated services for mental health and substance use. There was a tendency for our programs to be more mental health focused and having more cursory assessments and interventions for substance use. There was a tendency for programs to be, we also wanted to get an idea of what the field needed for ongoing expansions of CCBHCs and supporting them and providing integrated co-occurring treatment. To give an example of how we have grown regarding CCBHCs, in 2023, we had 28 CCBHC sites, which was a combination of those from the SAMHSA grant and those who were specifically demonstration sites for the state. This expanded to 19 more states in 24. We don't have the final decisions yet for fiscal year 25, and we're estimating we could have a potential of up to 12 more sites for the next fiscal year. Due to the state's requirements for CCBHCs, we are also expecting that our ACT and IDDT dual teams and our IDDT only teams could potentially expand up to 10 more teams compared to our current 69 ACT IDDT teams and our 12 IDDT only over the next year. Next slide. Thank you. So before going on to, our priority was twofold. We wanted to support our Michigan Fidelity Assistance Support Team, also known as our MyFast reviewers, by providing quarterly specific topic trainings to increase their knowledge of integrated treatment to improve inter-rater reliability on the IDDT Fidelity tool and improve consistency of technical support for the application of integrated treatment in the field. We wanted to utilize data from MyFast visits, surveys, and quarterly meetings to create a training curriculum to enhance knowledge and application of integrated treatment and interventions for the behavioral health field. During this project, we collected information from surveys, site visits, the Practice Improvement Steering Committee, Co-occurring Leadership Committee, the Motivational Learn and Share to assess training needs. We were able to provide one training for the MyFast reviewers and have our second one scheduled for to have on September 24th of this month. We provided our first 2-day ACT IDDT Summit, which had well over 100 participants. We provided 13 other trainings to the field, which included an 8 2-hour webinar series. We've been working on creating our fiscal year 25 curriculum, which will include another 2-day ACT IDDT Summit, a minimum of 6 IDDT basic trainings, 6 advanced IDDT topic-specific trainings, such as assertive outreach, engagement, staged match treatment, co-occurring basic and advanced assessments, strength-based co-occurring treatment planning, 8 2-hour webinar series, which focuses on different substances and how the substance and mental health impact each other, supervision for integrated treatment, cognitive behavior therapy with co-occurring disorders, and continue our ongoing motivational interviewing cohorts. The biggest lessons learned was to have ongoing persistence and determination to engage and maintain relationships from a perspective of how we can integrate, collaborate, and keep focus on how it benefits everyone. From this project, holding on to the hope that even if not today, we are planting seeds for tomorrow. The other lesson is that it's not just providing training, it's providing the tools to apply integrated treatment in the work we do. And from that, I will hand this over to our friends in New York State.
Hello, thank you. I just wanted to start by introducing myself. Stacy Hale. I am the Director for the Bureau of Rehabilitation Services Treatment and Care Coordination for Adult Services at the New York State Office of Mental Health, and I will pass it over to Shannon.
Thanks, Stacy. Hi, everyone. I'm Shannon Fortran. I'm the Director of the Children's Outpatient Unit, also with the Office of Mental Health, and we're happy to be here with you today. Okay, so for our case challenge, we are a little different from some of our colleagues that you heard from today from other states. We have 2 separate state agencies that govern mental health and substance use. So as you can imagine, we're operating with 2 separate budgets, different regulatory frameworks, separate policies, training, staffing. So they're quite siloed, which makes integrated care both at the state oversight perspective, but also on the ground level for our programs quite challenging. Now, because of this, the behavioral health system lacks a cross-system knowledge, and the treatment and intervention approaches differ, as does our guidance and our trainings that are offered to the system. So as you can imagine, because of that, with separate programming, it can be challenging for individuals and their families to receive care holistically. And while New York State has taken steps towards developing mechanisms for specifically our outpatient programs to serve mental health and or substance use, we recognize that more needs to be done if we're going to move towards a no wrong door approach. And New York State is committed to supporting a behavioral health system that is readily accessible with quality outcomes. And because of that, because we have that synergy across those 2 state agencies, we have ways in which we can achieve realistic and achievable actions that can bridge these 2 systems. So our first step in our case challenge was to develop a vision and a plan to make integrated care a consistent standard in our outpatient programming. So as far as our objective, our progress, and our lessons learned, given there are 2 separate state agencies overseeing mental health and substance use programming, we prioritize developing a vision that both parties can agree upon. So even though we're committed to getting there, we recognize that this is the bedrock for future planning. So from there, from our agreed upon vision, we needed to map out a strategic plan to achieve this shared vision. And while both state agencies are equally committed to supporting a robust outpatient integrated care system, we acknowledge that the who, what, when, where also needs to be agreed upon. So ultimately, we want to move towards a system in which programs are competent and equipped to support serving mental health and or substance use needs. And we want to move away from a system in which individuals and their families are needing to seek care from multiple programs to get their needs met. So as far as the progress that we've made, we quickly learned that all facets of our mission were interconnected. So we have our vision, right? We know what we want to achieve. And then when we developed our strategic plan, we realized that every part of that plan could and needed to be interconnected. We couldn't, for instance, talk about policy without talking about regulatory framework, without talking about fiscal. So because of that, each department within the state agencies needed to contribute towards the overall plan. So we created targeted work groups in which members from each state agency were required to attend. These work groups meet routinely to develop sections of the plan. And further, because New York State's experience with CCBHC implementation, we have already the foundation for cross-agency collaboration and lessons learned through that exercise. As far as our global lessons learned, we've learned quite a lot. Despite the shared vision, we definitely acknowledge that we need to assess for system readiness and engage stakeholders to elicit buy-in. So even though at the state level, we're very committed to an integrated behavioral health system, we do need to assess for where the system is. And further, we need to specifically identify individuals who are kind of like the task managers or the champions to keep the group moving forward. And we've also had to account for cultural differences between the two systems that has proven to be quite critical to this process. So I just want to, before passing it on, I just want to acknowledge and thank SAMHSA for this opportunity and from what we've learned from other state partners. And with that, I'll turn it over to South Carolina.
All right, good afternoon. I'm Grace Lambert. I'm the Integrated Care Manager with the South Carolina Department of Mental Health. And joining me is Erin Lauder, who is over co-occurring programs at the South Carolina Department of Mental Health. And so we are presenting on the case challenge that we worked on as part of the Learning Collaborative.
Hi, everyone. I'm glad to be here. I've learned a lot from the other states. So to provide a bit of context for South Carolina and across the United States, there are 19 states that have fully integrated human service agencies. That means they're in one entity. And 12 states have mostly integrated services, and that's two separate entities. And then 18 states have somewhat fragmented agencies, and that could be up to 3 to 6 entities. And only one state is completely fragmented with 7 entities, and that is South Carolina. So we've had some challenges in integration because of that. South Carolina ranked 43rd nationally in health outcomes and has the most fragmented health and human services structure in the United States. Constituents face barriers at each step in finding and accessing benefits and services for mental health and substance use. The South Carolina Department of Mental Health and Department of Alcohol and Other Drug Abuse Services operate 2 separate systems. These factors result in disjointed care and confusing access points. These contextual factors motivated our focus in the case challenge. Services, oversight, and funding systems have been siloed, which has made it difficult to integrate care. So far, South Carolina Medicaid has not been willing to commit to a PPS system or payment system, resulting in an inability to apply for a CCBHC planning grant. Gaps in data collection and sharing among agencies limited the understanding of individual interactions across the systems, making it difficult to track outcomes. The South Carolina legislature failed to pass legislation last session to create a new health agency that would combine the 2 entities. Therefore, our case challenge focus is to create a portal to share information among the agencies. We hope this will better connect those who would like to partner, learn, and connect on integrated initiatives. The use of a SharePoint site will increase dialogue and opportunities to enhance collaboration and coordination between agencies. And also there is talk that this legislation to make the one health agency may pass next year. So we hope by having this information all in one place, that it'll be helpful as we move forward. Our priority, next slide. Our priority objective is to create a SharePoint site to improve education, knowledge, and awareness of what substance use and mental health agencies are working on as it pertains to integrated care. South Carolina has developed a SharePoint site and information is being gathered to populate it. And we're hoping to have that completed this month. Through the Learning Collaborative, South Carolina has learned that having legislation to change the structure of how mental health and substance use treatment and services are provided is important, but that doesn't mean we can't collaborate. And that concludes South Carolina's presentation. I will pass it off to Texas.
Thank you so much. Good afternoon, y'all. My name is Sarah Malecki. I am the Director of Integrated Care Strategy within the Behavioral Health Services Division of the Texas Department of Health and Human Services. My colleague Susie was not able to be here today, so I will try to hold it down for everyone, for both of us. If we could move on to the next slide. When we were looking at our case challenge, the first thing that we identified is that we have a pretty strong base here in Texas. We cover a wide range of outpatient mental health and substance use services through our publicly funded programs. And we are also lucky enough to all be not only within the same agency, but also within the same division of that agency. But our structure has been siloed in many ways. And that leads to difficulties for providers who are trying to integrate care. For example, our data reporting requirements and our systems differ, the assessment processes differ, and regulatory requirements differ. So in the fall of 2023, before we were added to this learning collaborative, we actually hosted a series of 18 stakeholder listening sessions to get more information on the main barriers Texas providers face when they are trying to integrate care. And most of the people who attended and provided comments were representatives of our Texas certified community behavioral health clinics. We've got 44 of them here in Texas, and they are really on the front lines of integrating care. So the information that we gathered from those listening sessions have served as the basis for our work for this learning collaborative and within this area. The case challenge goal that we chose is very ambitious and will be an ongoing focus of our work because in Texas, we don't do anything small. So we've chosen a goal that will take us, a while to accomplish. To meet it, we have created a Texas HHSC work group that includes staff who work on our Texas CCBHC initiative, our substance use programs, mental health programs, facility regulation, and contracts. And then we also bring in staff from our data team, our budget team, and Medicaid as we need them. Next slide. Looking at our priority objective, the work group started out looking at data. We wanted to get a picture of how many people we are currently serving who can be identified as having co-occurring substance use and mental health needs. And we also wanted to find out how many people are getting both service types that are delivered through our publicly funded programs, either through federal or state funds. We started this out by completing 3 data pools. So the first pool used only substance use data, and it looked at identifying people with co-occurring mental health needs and identifying whether they had been connected with a mental health service and were currently using a mental health service. The second used only mental health data and looked at that same thing, but for substance use. And then in the third data pool, we attempted to identify people using services from both our publicly funded substance use and mental health programs. What did we learn? We learned that often, although we have a lot of data, data that we have for mental health services and substance use services is not necessarily comparable. For example, a number of our substance use data points related to mental health needs of people who are receiving substance use services, those were based on self-reported data, while mental health data was based on assessment information. But substance use needs are a pretty small part of that mental health assessment. They don't go into as much detail, understandably, because it is a focus on mental health. So where we could compare, it was difficult to conduct a data pool because the data are stored in 2 different data sets. We have a great data team, and they ended up working at the individual person level to get data related to how many people were receiving services through both publicly funded substance use and mental health programs. But we have started working on trying to come up with a long-term fix as opposed just to like ad hoc data pools. So we're working with our data team to develop and improve our ability to pull integrated data. And we're also now working to compare our substance use and mental health assessments and the data points that we capture from those assessments and other parts of the process to identify areas where we currently have alignment and areas where we may be able to have alignment in the future. And that is it for Texas. So I think I'm turning it back over to Kathleen.
Thank you so much, Sarah. At this time, we will begin the question and answer segment of the presentation. So if you have not already done so, please submit your questions by using the Q&A feature that is located at the bottom center of your screen. I do have a couple of questions, or I guess discussion points, that came through as folks were registering for this session. So what we can do is start with those questions. And one of them is, Sarah, very directly related to your data discussion. And I know that folks had very limited time to present, but the question was around best practices for data in behavioral health integration. So I'm wondering, Sarah, and others, of course, if there are some other strategies that you might want to elaborate on, since that was such a very pointed question from one of our audience members.
I am happy to take a first pass at this and would love it if my other state colleagues weighed in as well. I think for us, when we first identified that a lot of our data were not comparable when we were looking at people with co-occurring needs, that did become an area of interest for us. So we are looking at what can we do within the requirements that we have today for our funding sources to try and get some comparable data. Again, it all comes back to funding sources and what is required to be submitted to the federal government or maybe at the state level. So how can we try to align what we gather so that we're capturing data that is comparable across both systems?
Other states who were involved in the Learning Collaborative, more to add?
I think so. This is Stephen from Indiana. I think one thing to add to that is, as Mark and I started this, we were fairly surprised at the lack of data that we were getting from our OTPs, or that we were collecting from our OTPs, I should say. So, I mean, in terms of best practice, it's a lot of you don't know what you don't know. And going off assumptions has been really a detriment to a lot of these things because we assumed we had that information. So seeing that and hearing that from our data team really is helping us rethink how we're going to go through things.
Sierra, I'm not sure how we open this up to attendees, to participants, if there are folks that would like to also jump in if they have some suggestions or comments.
Yeah, if they raise their hand
Got it.
or
Okay.
request, I can allow them to unmute and speak.
And no pressure, but I know we have some smart folks on this call. Okay. Okay, this next question, I'll move on since I'm not hearing from folks, but please jump in, write in the chat if you would like. We really do want this to be a dialogue if possible. What are effective coding and billing strategies? So that was another question that came through as folks were registering for this this webinar. I touched upon some issues related to kind of broadly thinking about this at the state level, working with folks who are setting those codes, who are setting that kind of taxonomy. From our Learning Collaborative folks, what are some ideas that you might have for effective coding and billing strategies?
This is Raphael from Illinois. I don't have effective coding strategies, but I would say that it's critical to work with your Medicaid authority. This really goes beyond individual grants and really gets into how the different services are being coded and go through the Medicaid authority. I think so. It's critical to involve them in your process as you're looking at trying to figure out how to bring this about.
And Raphael, how did you make that happen? Did you literally just do, I don't want to say cold outreach, because I know that you folks know each other and work together, but how did you get them engaged in something like this?
Well, we're just starting the process of integration. So like I said, I really don't have an answer for the coding strategy part of this. But it is important to have that close relationship with your Medicaid authority, because at this point, a lot of services are being covered by Medicaid in some states. And so I think going in with a good relationship with your Medicaid authority is important. So we haven't started that process yet, but we have a good relationship with our Medicaid authority, and Orion would agree with this. And we work closely with them in a variety of places, especially now with Illinois has become one of the states with the CCBHC waiver. So we've been closely involved with them in all aspects of this.
I think the only thing I would add to what Raphael said is just making sure that we're at the table for all the conversations around CCBHCs, both from the mental health and substance use side, has been really helpful. In ensuring that what the Medicaid authority is doing in terms of designing the implementation of CCBHCs is equally integrated as the work that we're doing as the mental health authority and substance use authority. That we're all speaking the same language and thinking about the transition to CCBHCs in the same way.
Great point. Other folks can jump in on this coding and billing strategies question.
I was just going to add in, just kind of echo kind of what Raphael said about getting, being at the table with your Medicaid office. I think that was a major step that we found in Indiana, especially when trying to figure out what OTPs were capable of providing under their Medicaid bundle. It was very important and something that took too long for us to figure to get scheduled. To really talk it out with somebody from the Indiana Office of Medicaid Policy and Planning. I don't know about any other states, but Medicaid policy in Indiana is very confusing at times. It was probably designed that way, but that's another thing altogether. But talking with somebody to talk through some of the nuances and see what's possible. I just want to echo that yes, Medicaid definitely is a resource to bring to the table.
Other comments? Okay, let's just open this up for folks to reflect upon what they learned. If there are other questions that you might have, again, raise your hand. Thank you, Sierra, for that guidance. Any specific questions for the states, for individual states? Okay, I won't make this painful for folks. We'll go ahead and move on to the next slide. If questions do come to mind, please reach out, either it's still in the Q&A or reach out to us after this session. We'll be glad to get some answers for you. Okay, so I do want to talk just really briefly about this upcoming resource. I've referenced it a couple of times. Some of the strategies that I mentioned in my early slides directly come from this resource document. So this Integrating Behavioral Health and Learning Collaborative resource document summarizes our various sessions and kind of some strategies, some barriers and some strategies or remediation strategies that are mentioned by our subject matter experts. Also provides a list of various resources and links that might be helpful as folks are thinking about integrating behavioral health. So that is something that will be available to states at a later date that I think you might find helpful. And again, it will also kind of elaborate upon some of the quick points that I was making early on in this session. And the next slide is an important one. So thinking about accessing technical assistance and resources for states who are interested in accessing state TA project services. If you're needing some one-on-one with the state TA team, here are two important links. So you've got your SAMHSA state TA at jbsinternational.com, and then you also have to request a TA, a specific TA. You have the stateta.samhsa.gov link right there. Key items that need to be submitted in your request will include a brief description of TA and the basis of the request. You need to have an account to log in. All requests will be reviewed by the mental health block grant planner or the other coordinators, and it goes through a SAMHSA. There's like a whole process for reviewing and then approving those. And then once approved by the planner coordinator, the state TA team will follow up to set a call to obtain more specifics about the request. So just to let you know kind of how that process works a little bit. And if you're interested, please reach out. And I think we are at the point of evaluation. So again, just to reiterate, this is an anonymous survey. We would really like to get feedback from folks on how you think the webinar went, recommendations that you might have for us, because we will continue to do these webinars as we wrap up learning collaboratives in the upcoming years. So you've got your link right there, which I think we can drop into the chat. And some folks do prefer to use the QR code. That's also totally fine. Either one of them will take you to the same survey, literally 5 minutes to complete this. So hopefully you'll take the time to do that. And then just wrapping up with, we've got a thank you slide at the end here, but we'll leave it here for just a moment. Hopefully everyone can access that link. All right, Sierra. And we have our thank you slide here. SAMHSA expresses their deep appreciation to the states that participated in the Learning Collaborative and presented at the webinar. Just reiterating what Tara said at the very beginning of this session, really phenomenal states working with us and being so committed. And if you have completed your survey, or if you're in the process of completing your survey, that's the end of the webinar.